Okay, good afternoon. I just wanted to say it's really fun to be here and interact with you, so please keep asking questions. We were talking the last few days. The question is, and we need your feedback on this, how high do we aim for the content? Because some people say, well, it should just be a low-level basic, but I think if we aim really high, then you can kind of see what's before you in terms of how much there is to, acquire during your time as a resident and beyond that. So we may need your feedback during the evaluations to make sure we're going on the right track for future years and your colleagues that are coming up behind you, because there's some people that say, no, you should just keep things at a very basic level. But I think for me, and I know when I'm learning, more detail and higher level, it's really helpful to know how much you really should know about something and how it applies. So give us your feedback, because we need to go forward and make it better and better each year. And Dr. Hammer and Rafi put a tremendous amount of work into developing this, and we want to continue to build on something. So please, give us your feedback, because we want to make it as good as we can. Okay, we're going to cover other territory now. Third nerve. The reason I decided to spend a whole lecture on third nerve is probably, of all the cranial nerves, it's the one that there seems to always be a question of urgency and how much this is going to, how dangerous these things are. So I want to talk about cases of different types of third nerve palsies, and I want to just first quickly cover the anatomy. Need a credit card to get in. So this isn't as complicated as it looks, but this is just a side view of the midbrain, pons, and medulla, just showing the location of the different cranial nerve nuclei. And just obviously, you probably already know that in the pons is mainly where the trigeminal nerve and sixth nerve and gaze centers are for horizontal gaze, but really everything for the third nerve is in the midbrain. And remember, these fascicles exit the ventral part of the midbrain. The only cranial nerve that exits the dorsum is the trochlear nerve. All the rest exit ventrally. You see this in different books. This is from Walsh and White. This is showing the topographic spatial organization of the third nerve nucleus. And I think this is a little deceiving. This comes from the work of Warwick. Warwick was a very good investigator that studied the anatomy of monkeys, and they injected a tracer, horseradish peroxidase, into each muscle, and that's transported back retrograde into the brainstem to see where the nerves that go to each muscle is localized. And if you go back to his original work, it doesn't look like that. I mean, there's concentrations of neurons in these areas. But the main thing, the main point I want to make is that, I'm going to show you another diagram. This is kind of a three-dimensional organization of the third nerve nucleus. And a couple things you should know about it that has some clinical significance is that, first of all, the levator area, so this is rostral, and this is posterior, and this is dorsal and ventral. So levator complex is here. The superior rectus has both crossed and uncrossed. So if you get a lesion in the third nerve nucleus affecting the superior rectus subnuclei, it affects both eyelids, maybe asymmetrically, but both sides. And I had a Westphal nucleus here, inferior rectus, inferior oblique, medial rectus. And so this is it from the sides. So this is rostral up here, so this would be towards the eyes. And again, back here is the caudal nucleus where the levator complex is located. Here's the visceral nuclei, accommodative and pupil, and the Edinger-Westphal nucleus. And just so you know, there is a topographic organization to where these neurons start. And then just diagrammatically, if you're looking at MRI sections, axial sections, you'll know you're in the midbrain when you can see the aqueduct. So some people say that that looks like Mickey Mouse. So easy way to remember you're in the midbrain. And so here the fascicle of the third nerve is coming out. And remember, the basilar artery is coming up, and this is the end of the basilar artery. And it gives rise to the posterior cerebral artery and the superior cerebellar artery. And that's where the third nerve comes out between those two, right there. And here, remember, we talked about the posterior communicating artery. So if there's an aneurysm here, it would press medially on the third nerve. So you already know that. And then anatomically, the third nerve, as it comes through the cavernous sinus, it divides as it comes into the orbit into a superior branch and inferior branch. So the superior branch of the oculomotor nerve supplies the levator and superior rectus. So if you had a superior division third, you would get failure to supraduct and ptosis. If you have just an inferior division third, that supplies the medial rectus, the inferior rectus, the inferior oblique, and the pupil and accommodation. So you would spare levator and supraduction. And the important point that some of these cases are going to drive home, I really want you to try to remember, if you get a divisional third, all of the muscles supplied by that division are usually affected in the same equal proportion. In other words, diseases, if you got something affecting the inferior division, it wouldn't just affect adduction and not infraduction. Or it wouldn't affect, these happen in proportion to one another. So when you see disproportionate weakness of muscles in the same division, then you start thinking about something besides third nerve palsy. It might be myasthenia. So keep that in mind. That's a constant theme. And again, just showing some correlations with MRI to see where the third nerve, where you'd look for it if you're looking for third nerve enhancement in terms of where these fascicles exit the underside of the brainstem, of the midbrain. And again, this is a cadaver, and this is showing, here's the brainstem, we're looking at it from the ventral surface. Here's the basilar artery coming up. And it's ending with the posterior cerebral artery and superior cerebellar, and here's the third nerve coming out. And here's the carotid arteries. Okay, first case. 7-year-old who complained of horizontal double vision and now oblique vertical double vision that progressed over 3 weeks. And I'm going to show you her 9 cardinal gazes in the next photo. And I want you to try to work through what's weak and what might be the cause. Okay, so primary gaze, and you have to kind of look at the versions and also the corneal reflexes, but how about in primary gaze? Do you think that there's very much misalignment, or it looks pretty aligned? Might be minimal misalignment. Looks pretty. I think that it's probably not lid retraction. It's just that she was asked to keep her eyes open. How about looking to the left? So the right eye adduction. So I think it's very good that you picked up on that. What I do is I look at how much the right eye adducts compared to the left eye. So here there's no sclera seen, and here there is. So you're correct. So there seems to be a right eye adduction weakness. Okay. How about infraduction? Any difference there? So kind of putting a line across the limbus. Do you think they're pretty much in alignment or not? Okay, so maybe the right eye doesn't quite get down as far. So we've got an adduction deficit, a little bit of infraduction. How about looking to the right? So abduction compared to this side, not quite as good. And then how about superduction? And you can look at the corneal reflexes too. So superduction isn't quite normal either.
Little bit from everything.
Yeah. How about the eyelid? We can go back to the previous picture.
1 millimeter difference, no more.
Okay. Yeah, he said maybe a millimeter at the most. So let's try to put this together.
And pupil is the same size.
Right. So on one hand, we saw kind of a significant adduction, but infraduction was pretty minimal. It looks almost normal. Superduction was affected, but the lid doesn't look like it's that affected compared to the superduction. Right. You just can't make it fit. Okay, myasthenia, that's a good thought. So yeah, if it doesn't fit a nerve palsy. So I think about, nuclear, infranuclear, which is the cranial nerve, neuromuscular junction, which would be myasthenia, and then muscle, so something's wrong with the muscle itself. So the important point is it didn't quite fit. We want it to fit, and neurologists love to call something a cranial nerve palsy right away without thinking about it. Thyroid. So would this be a thyroid problem? So which are the muscles that are most affected in thyroid eye disease? Medial rectus and inferior rectus, and it's restrictive. So that would fit with a superduction because the inferior rectus is restricted. And would fit with an abduction deficit because the medial rectus is restricted. But it doesn't quite fit with adduction because the lateral rectus usually is not very affected. Yes. Well, it progressed over about 3 or 4 weeks. But we don't know. We just know it started out horizontal and became vertical. Well, this was the fundus exam. And, well, there was a big choroidal mass that was not pigmented. And so she ended up having metastatic lesions to the muscles. So I just threw that in there because you're expecting my first case to be a third nerve, but it wasn't. Just because the lecture doesn't mean everyone's going to be a third nerve, right? So you have to work through this in your mind. Don't fall into the trap of calling everything a cranial nerve palsy right away. See if it fits. Ultrasound and MRI and CT scan. So metastatic lesions to the muscles are very easy to see. Yeah. Okay, easier case. So this is an 88-year-old who's noticed a progressive drooping of the eyelid, and she finally came in because it's all the way down. And here was the trying to look up. And here's, I'll give you the 9 cardinal gazes here. So you tell me, you have to go through each gaze and see what's normal or abnormal. So how about, first of all, in primary gaze, looking at the corneal reflexes, what's obvious? Right, the eye's lower, right? Because it can't, that right eye just can't look up. And how about introduction? Looks good. And how about adduction? Looks pretty good. And abduction looks pretty good. So what do we got? We've got superduction, doesn't really get past the midline, and complete. Right, so now we're talking about a superior division third. Now, if you were to, if you were on a game show and you were trying to guess what would be the most common cause in a slowly progressive superior division third in an 88-year-old, what would you guess? This is her 1,000 chromer. What?
Orbital lymphoma.
Orbital lymphoma. Okay, so that's a possibility. Okay, so that would be hard to affect just the division, superior division.
It can start. When it comes with the roof of the orbit, it doesn't come in the bottom. It usually begins with the roof.
Oh, I didn't know that.
It's literature.
Okay.
No, we don't know exactly, but
What do you think would be the most, this is painless. What kind of slowly progressive thing that affects the cranial nerve and okay, so vascular, that would be an immediate event, and then it would usually recover over time. So vascular doesn't quite fit. What of the lacrimal gland? A what? Tumor of the lacrimal gland. So tumor of the lacrimal gland wouldn't really cause a superior division third. It might make a globtosis, and it wouldn't affect motility this much, and it wouldn't affect ptosis, I don't think. So you got to think about chronic progressive superior division third in an older person. What's the most common causes of progressive cranial nerves in older people? Okay, what kind of tumor? What kind? Okay, here's the CT scan. See if that helps. Anything, this is a right superior division third. Anything different about the right side compared to the left side? Let me show you the bone window. Okay, who said meningioma? Okay, you get the prize. So we got bone changes right here, and really meningioma should be at the top of your list for older people that have chronic progressive tumors. Okay, here's a little boy that got his finger stuck in his nose, And look what happened. So the story was he and his brother were playing in the yard, and he came running in the house crying, and this is what the parents saw and brought him in. And so I'm going to show you another picture, but so the eye's out, and he didn't have any dilating drops. And then this is him kind of looking to the left and down. So go back again.
Is it the primary position?
That's primary position, yes. Yeah. So let's first figure out what's wrong. So first of all, the eye's that far out, so we have to assume that adduction's not working at all, right? And the pupils looks like it's been pharmacologically dilated, but it hasn't. So that means the pupil's involved, right? And then it didn't look like that this eye was getting down like that eye. But how about the eyelid? Alex?
The superior branch is reserved.
Preserved, right. So it looks like an inferior division, third.
It's in the orbit.
Right, so the question is, how can a 3-year-old playing in the yard with his brother get an inferior division third? Well, we did a little more questioning, and he and his brother were playing sword fight with sticks, and the brother stuck him, and when we pulled down the lower eyelid, there was an entry wound. So he got a skewer into his inferior division third. So that was kind of an interesting case. And this happened about 3 days before we saw him. And here's with both eyes open, and then this is after dilute pilocarpine. So there's a small pupil now on that side, super sensitive, so you'd expect that, right? Okay, here's another interesting case. This was a woman who was seen in the comprehensive ophthalmology clinic 3 weeks before, who complained of double vision with reading. And she was diagnosed with convergence insufficiency in our comprehensive ophthalmology clinic and sent home with exercises. And then she came back to us 3 weeks later, and she was kind of talking like this, and she said, my neighbors think I was drinking and I'm walking funny, and now I have more double vision. Okay, so this is how she looked just straight ahead. Let me show you her cardinal gazes. So give me your opinion here. So let's see, first let's look at gaze right compared to gaze left. So here's looking to the right, looking to the left. Any difference between the alignment comparing the two? Well, let's first look at abduction. So abduction, what do you think? Normal? Abnormal? Hmm? Okay, so you think the left eye, there's an adduction deficit because it doesn't bury as much of the iris as it does here. Okay, so you're thinking there's some mild adduction deficit. How about superduction? Pretty good. And how about the eyelid? I'm pulling her lids open, but the last slide.
Hip position.
It's pretty good. How about introduction? Also not quite as good. So we've got an introduction and an adduction, but superduction and lid look pretty good. How about the pupil? Okay, let me show you a little bit higher magnification. Whoops, bright light. A little bit of weakness. That's why you have to use a bright light, especially when you're called in to see these patients to see if there's pupil involvement. Bright light. Okay, so we've got superior division is intact and inferior division isn't. And this has been progressive over 3 weeks. And also, this was a long time ago, our first electronic pupilometer, so this shows that the anisocoria is getting greatest at the peak of contractions. That's why you want to use bright light in your clinic to bring out that weakness. So you see how we're using all these pieces of information we learned earlier. So, localizing this, we said slowly progressive, inferior division third. Where do you expect the lesion to be?
Doesn't she have trochlear affected in the other eye?
No, she didn't. So we're having to localize a slowly progressive inferior division third.
Should be in the orbit?
In the orbit, okay, because we showed that anatomy slide that showed where it divided, kind of in the anterior cavernous sinus, first part of the orbit, so that's a good candidate. But the other part, remember I said she had been talking funny, like she was drunk and she was kind of walking funny. So how do you put that together with an inferior division third? That she said she doesn't drink. So how do you localize that? Let me show you her. This was an MRI scan from a long time ago. It's not as good a quality, but this was her scan. This is the sagittal section, and this is the axial section. Anything look funny there? You don't have to be a neuroradiologist, just anything that just doesn't look right, even if you don't know what it is. That? Okay, that's normal. But think about where you're trying to look for a cause.
The orbit.
The orbit, okay, so the left orbit, gee, I don't see anything that's standing out. In the midline, this thing? What? Okay, so that's that ethmoid sinus, that's normal. But where should we be looking?
In the orbital, in the medial orbital wall, in the left eye, I think. Here.
Well, I don't see any difference there.
Yeah, there is difference, no?
Where do you see a difference?
There is bone change.
Well, MRI, you don't see bone.
The nasal cavity.
The nasal cavity.
The nasal cavity. So this is just ethmoid sinus. This is normal mucus. That's okay. But where did we say? This? What is this anyway? This? But what's this? That's the midbrain. What is that? Here it is in the sagittal section. So here's the pons, here's the midbrain, here's the medulla. What is that? That, ladies and gentlemen, is a giant basilar artery aneurysm. Now, that goes against what I told you, because we said that the third nerve divides in the anterior cavernous sinus and orbit. So now what am I telling you? But she had other neurologic symptoms that puts it kind of in the midbrain and the fascicle of third nerve, where get ataxia and both of the voice and the motor. And yet I said the third nerve divides here, so how can we have something back here? Well, here's another thing you should know. The fascicle, the fibers that are coming out of the third nerve nucleus, so this is inside of the brainstem, they have a topographic organization, starts right away in the nucleus. And even though anatomically the nerve divides in the orbit, it's organized topographically all the way back in the brainstem. So there's a number of papers published where you can get something happening to the fascicle and get a divisional third, whether it's a vascular lesion or a small tumor. And so the point I'm making with this case, I deliberately misled you, I apologize, is that just because the nerve divides anatomically in the orbit, or posterior orbit, you can get a divisional third anywhere along the course of the third nerve, even proximal on the brainstem, like this case. Okay, this is a woman who looks like this in her hospital bed. I'll show you her motility here in a second. So it looks like the lid's down completely on the left side. Let's look at her motility here. So, looking to the right, that eye gets out, but that eye does not do anything. So it's complete adduction deficit. And looking down, doesn't, matter of fact, both eyes don't get down very well. And looking up, this eye definitely doesn't get up, but this eye is not quite normal either. As a matter of fact, it makes you start to wonder whether that lid is normal too. So we've got asymmetric but bilateral ptosis. We've got asymmetric but bilateral superduction deficit. And neither eye gets down very well. And this eye doesn't get in. This eye probably still doesn't get in completely. So it looks like there's almost a third nerve on both sides, but this eye is more complete. Yeah? Right, so you start to wonder, is this a nuclear? Because how do you get both nerves like that? And also, this is what her fingers look like. You ever seen that before? You guys do 2 years of internal medicine or 1 year before your ophthalmology? Right? You don't do that anymore? You do, but that's already gone. You've forgotten all that. 6 months, okay. So how about if you have something in the brainstem and then this in the fingers? And oh, syphilitic. I don't think that would cause lesions like that on the finger. It would be in other places, maybe. This was the MRI scan. And here's Mickey Mouse, right? Here's the mouth. And so something happened here. Here's where the third nerve nucleus lives. But also, there's something else going on here too, both occipital lobes. Can I tell you she also had a left branch retinal artery occlusion?
Beginners? Beginners? Beginners.
Oh, Wegener's. So necrotizing granulomatous disease. So that could cause a vasculitis, yeah. But when you see those things on the fingers, those are embolic lesions. So this is an embolic phenomenon. But
infective endocarditis. Infective endocarditis.
louder?
Infective endocarditis.
Yes. So this is very good, thank you. This is endocarditis. And just happened to hit the third nerve nucleus. But you don't see that many examples of nuclear lesions, but this was a good one, so I wanted to put it in there. What's our time on this lecture?
Another 12 minutes.
12 minutes, oh my goodness, okay. Here's another patient who had, couldn't open his eyes. Neurology insisted that this was myasthenia. So we did a myasthenia test, prostate, didn't get any response. And this was the motility, so he could get both eyes down. He could get both eyes over to the right, both eyes over to the left, maybe couldn't quite get the eyes up all the way, but definitely both lids he couldn't open. So how do you get a lesion that would affect both eyelids? The other thing that was interesting, did you see how small the pupils are? Even in darkness, the pupils were small like that. So here was a scan. So now Mickey Mouse has a lot of lipstick on. And here's the coronal section. So this was some periaqueductal gray, and right where the caudal part of the third nerve nucleus. Remember what was located there? That was the levator complex. So we got the levators from whatever this is, which turned out to be a lymphoma. And the reason the pupils were small is that we didn't get a chance to cover this in the pupil lecture. Normally during wakefulness hours, the pupils are mid-size, right? And that's because there's the reticular activating formation, which is our kind of awake center, is firing, and it sends inhibitory fibers to the Edinger-Westphal nucleus. Because normally those neurons in the Edinger-Westphal nucleus are different from other neurons in the brain. If they don't have any input, they fire like crazy all the time. And so if nothing's inhibited in them, they're small. Right, so that's when you go to sleep, the reticular activating formation, it goes down, and no inhibition, the pupils get smaller. If any of you rotated through anesthesia, as soon as you go under general anesthesia, the pupils get small. Same thing with narcotics. And that's what makes the pupils small, disinhibiting the Edinger-Westphal nucleus. Those fibers that ascend from the reticular activating formation to go to the Edinger-Westphal nucleus, they travel in the periaqueductal gray area. So anything that affects that area will give you small pupils that don't dilate or do anything in darkness. Because remember we said two things make the pupils dilate. You have to inhibit the parasympathetics, the antagonist muscle. But here we've got something that's taking away any of the inhibition that's possible. So even if the sympathetic's firing, the sphincter muscle is clamping down.
Inhibiting the vestibule nucleus coming only from the cortex?
No, it's coming, the reticular activating formation is down and lower in the brainstem.
But
It's also input from the cortex too, yeah. Okay, so again, this was the levator complex right here. This is right adjacent to the aqueduct, so his lesion was right here. Okay, this patient we already covered, so we can skip over it. That was the painful third with pituitary apoplexy. We talked about all the causes this morning, so you already know that. The experts. And this was the pituitary apoplexy. And remember we said that the pituitary gland, where it's located, is that the third nerve is lateral to the pituitary. So if it expands laterally, we'll get one or both third nerves. Expands superiorly from an apoplexy, you get the chiasm. Okay, so just things about apoplexy we didn't cause. Remember, we said it was an ischemia to the pituitary that causes edema and or hemorrhage. And classic signs are acute pain because of a sudden expansion, acute visual loss if it expands upward, and ophthalmoplegia if it expands laterally. And that's what it looks like on a scan, coronally and sagittally. So you could have either hemorrhage, is shown here, or just edema, which is shown here. And of all pituitary tumors, anywhere from 0.5% to 9% will get apoplexy. So it's not that rare. Okay. Two weeks ago, she had a bad headache, and then about couple of days afterwards to just have 2 medicine.
What's 4?
4 days later, she started to have some double vision. So headache first, then double vision. It was already a little bit bigger, got bigger on that side. And she's been having, last episode she had, this was in 93. Probably the first episode was age 7, and it was happening every year, but it hasn't happened since then. So she's had a number of these episodes since she was a child. I don't know why it makes the difference. So obviously there's an efferent defect here. Because a lot of people reacted like that didn't hurt anything. And then I'm going to have you, this is your eye movement, I'm going to have you look over to the right. That's good. And up and right. Straight up high. You can't get the eye up. And up and left. You can't get the eye over. And straight over to the left. And down and left. Keep looking down left and right. And straight down. And down. It's slide down pretty well, but not completely. And we don't have a chance to go over aberrant reinnervation, but we don't see a whole lot there. Eyelid aberrant movement. Okay, so interesting story. 30-something-year-old, this is the 3rd or 4th episode, headache, then ophthalmoplegia. It's always kind of the 3rd nerve. First episode was when she was a child. Okay, ophthalmoplegic migraine. We call it ophthalmoplegic migraine because it always is a headache followed by the ophthalmoplegia. But is it really a migraine? Because that's what it was labeled and it stuck. And she had an MRA, which was normal. There's no aneurysm. But here's her MRI without contrast and with contrast. What do you notice there? Remember where you should be looking. Got to direct your attention. So you've got some enhancement right here of the 3rd nerve. You can see it in coronal section too. What has been termed ophthalmoplegic migraine shows enhancement of the 3rd nerve. So, we call it migraine, but I don't think it is. No one knows what actually causes it. But enhancement of the 3rd nerve in this setting, it's benign, is considered this diagnosis of ophthalmoplegic migraine. They may resolve partially or completely. And you always get a history, usually, of them having the first episode as a child. So usually, a child presents with a 3rd nerve palsy, they get a pretty big workup. And it varies a lot. It can be happening repeatedly. This was the 3rd episode. So but the main part of the history you want to get is, has it ever happened before? So it's kind of interesting. We saw this case was the one that I made a mistake on when I was a fellow. And that was the aneurysm. I wanted to show you this diagram. So these are different cross sections through the 3rd nerve at location where it exits the midbrain. And right where it exits the midbrain, the pupillary and accommodative fibers located superiorly. But as soon as it enters the subarachnoid space, to see how they're medial on location. So this is where the posterior communicating artery aneurysms compress the 3rd nerve. And that's why it gets affected, the pupil fibers and the accommodative fibers, because of the location. We're getting to the end here. So here's a 80-year-old with acute ptosis. He's exotropic. The pupils don't look abnormal. There's not much anisocoria. This was a scan which looked pretty normal, except for this. The reason I'm showing this is the coronal section. See how the basilar artery kind of goes way over like that? People call that dolichoectasia. So with atherosclerotic changes, these arteries get thickened and ropey, and they often can cause either hemifacial spasm, or they can cause trigeminal neuralgia, or they can cause chronic cranial nerve palsies because they're more common. So these often present with ischemic nerve palsies, but it's just a risk factor that you should be aware of. You can kind of see its course is kind of, and it recovered over time.
Can you say the name?
Dolicho-ectatic. Dolicho, D-O-L-I-C-H-O, dolicho-ectatic. E-C-T-A, A-T-I-C, ectatic.
So it's not age-rated?
Yes, it's not born with it, yeah. And then here's the last two cases. We have time?
Sure.
Okay, this is a good one. This is a 17-year-old, and the history here is very important. He's noticed a gradual progression of worsening double vision over the last 10 years. And that's what he looked like. I'm going to show you the 9 cardinal gazes. Well, the pupil was involved. And here's his motility. So the lid's down a little bit. He really can't get that eye up very well. And he can't get the eye down very well. He doesn't get the eye in. So that's looks like a pupil involving third nerve, but it's over 10 years. And no other headache or anything else. So what in the world could cause a slowly progressive third nerve palsy in that age group? And also, this is quite a number of years ago, he came in with an MRI that wasn't very high quality, but there really wasn't anything noticeable except on this section. So you see that thickening right there? So these are intrinsic tumors of the third nerve. These are schwannomas. Schwannomas. And so these arise from within the third nerve itself. It's not an extrinsic tumor. And the story you'll always get, and if you can back this up with family album pictures, is that you'll see some of the changes in the childhood pictures at the time it started. And if you track it with the pictures, you'll see that they slowly progress. And they often enhance with a good MRI scan. Now this is the last case. This is a 44-year-old, and she had a history of a slowly progressing double vision over 6 months, not over 10 years. And so you can see, looking straight ahead, the alignment doesn't look too bad. What about the pupils? A little bit bigger on this side. Here's the motility. So here's looking to the right and looking to the left. So what do you think about adduction's not quite as good as on that side, is it? And that eye doesn't get down as well, and it doesn't get up as well. So she's got a pupil involving third that wasn't acute, that's slowly progressive, and no headache. So she had pupil involvement. So she had a scan, and she had a very enlarged, thickened, and enhancing third nerve. And if it was that boy and I had this scan and that history, I wouldn't worry. But a 44-year-old that's had progression later in life, I worry. So that was biopsied actually. That was a malignant schwannoma, and she was dead within 4 months. So those are very malignant. So just to give you the spectrum of benign versus malignant schwannomas, it's very hard to treat those. So I think that's the end. Yeah. So time for break?
Yeah, a 5-minute break until 5 minutes before 2.
What time are we coming back?
1:55.
1:55, and then we'll cover giant cell arteritis.